Bear with me, I'll just share. I don't know what happened there. I'm sorry, everyone. Stephen, if you can just allow me.
Yeah, sorry, I'm just going to find you now, Vicky. Bear with me 2 seconds.
Thank you.
Is your night? Is you? Bear with you, Vicky. I'm trying to work out who you are on the screen. Bear with 2 seconds. Ah, I can see you. I think. Do you want to just show your camera a moment, please, Vicky, so I know it's you? Thank you. There we are. Just making you co-host now. There we go.
Thank you.
Great. So I will carry on while that comes up. So just a little bit about our services. So yes, we know that we provide hospital services, and we deliver a lot of our healthcare in the community, either through primary care, our GPs, dentists, pharmacists, or in some of our community facilities like our community hospitals, in some of our health centres, and our developing health and wellbeing centres, of which we've got one partially developed, and we've got plans for another 2 for each of our locality. And of course, we've got a big responsibility in terms of public health. So that's about promoting good health, tackling health inequalities, and really focusing on the preventative agenda. What can we do to prevent people getting disease or illness in the first place? And when people do become ill, how can we prevent them getting ill again in the future? So next slide, please, Vicky. In terms of implementing our strategy, some of the things that we've done, I've just alluded to this. We've been developing our health and wellbeing centres in the community. You'll be aware that Malva, we've just had funding for from Welsh Government, and we're developing the Malva Hub co-linked with the local authority. Most recently, and in response to COVID, we've developed what we call primary choice, some work that our primary care colleagues have been developing, and the CAV 24/7 model that the Community Health Council's been very much supporting us with in terms of the engagement, to deliver a different kind of model around urgent care, a phone first model, in response to some of the issues and constraints we've had around COVID. Again, more recently, in September last year, we introduced the Major Trauma Centre. That was work that Vicky led in our health board, as part of the South Wales Regional Network for Major Trauma Services, following a consultation about where the right place was for developing the Major Trauma Centre. And then the last thing I want to say was about, obviously, the pandemic. That has changed our lives significantly over the last year. It's hard to believe that a year ago, in next week, we were facing the first phase of lockdown. But what we've done during that time is really changed the way that we think about some of our services. We've seen huge innovation. We've changed the way that some of our services are organised and delivered. We've used technology significantly more in terms of enabling people to access services in different kinds of ways. All things we've had to do to respond to COVID, but actually coming out of that, there's some things that probably will help shape services going forward as well. Next slide, please, Vicky. So just turning to the case for change then, I guess one thing that we do know is that staying the same and not making any changes is not really an option for us, because we know our population is continuing to grow. The expectations are that there'll be an increase of about 20% in the next 10 years. And we know that we have an aging population, and actually we have the biggest school age growth of population compared with any of the local authorities in Wales, in Cardiff, because we know that the city population is changing at a faster rate than in other places. When we did our needs assessment for the wellbeing plan and the social services plan, we identified that we have people who feel very lonely, and we know that people have that impacts on their mental health and well-being and life expectancy. We know that we have illness associated with lifestyle factors linked to the usual determinants of health, making sure people have got good homes, access to good education, and access to good work and meaningful work. So we know that we've got social inequalities and health inequalities between our most and least deprived communities, and that has a consequence on premature death, people dying earlier than they should and could, if we were tackling some of those issues. Next slide, please, Vicky. So just in terms of the case for change, other factors that are influencing us, the workforce. So we're one of the biggest employers in the region, 14,500 staff. And of course, we're a big teaching organisation. We teach more, train more next generation clinicians than any other health board in Wales. And we know that we need to have the right kind of environments for teaching, for training purposes as well. Now, colleagues amongst the CHC will be very familiar with our infrastructure and visit our buildings on a very regular basis, and come and do visits and talk to our patients and our staff. And we know that many of our facilities are not as they should be. They're not fit for purpose. They were built at a time when healthcare was delivered in a very different kind of way. And we've experienced some real challenges as a result of the buildings not really being fit for purpose anymore, particularly in our large hospitals. So, you know, UHW planned in the 1950s, built in the opened in the early 1970s. We've delivered so many more services now, very different clinical requirements as we move forward, and expectations for our population in terms of the sort of environment they can expect to be having their care delivered in. Next slide, please, Vicky. And then this is the final slide for me. So the other things that are factors in terms of the case for change. New diseases, obviously very relevant in the current climate, where we've responded to a pandemic, a new virus. The expectation is that probably will continue to inform, or we'll be required to continue to respond to new diseases and those sorts of issues as we go forward. But we've also seen real acceleration in the advancement of treatment. So something called precision medicine, where each person gets very personalized treatment based on their DNA profile, so that we can really target their treatment to the situation of each individual person. Digital technology, as we've seen, we're here this evening online. We've demonstrated, apart from being booted out from the system every now and then, that we can deliver things in very different ways. And a lot of patients are now receiving outpatients or consultations from their own home, either via phone or video. And of course, it's not for everybody, and it's not a one size fits all, but it does give us different solutions and enables us to deliver services in a very different kind of way. And then the final thing before handing over to Stuart is that we are a big contributor to the economy in South Wales as well, and in our Cardiff and Vale population. Not only are we a big employer, but we have people who come up with ideas that can improve healthcare, either some kit or new approaches through research or innovation. And that contributes to the economy, because those are things, ideas and products that end up coming into market and that can generate wealth and income in the region. And we recognise that we've got more to offer in that regard. And as we come out of the pandemic and we see the full impact on our economy, we recognise that we've got a real contribution to play in relation to re-establishing and regrowing economic growth in the patch. And the final thing to say is that we are very aware of the climate emergency and our responsibilities in respect of that. So that is also part of our thinking in terms of the case for change. How can we reduce our carbon footprint as a health board in the way that we deliver services and in the way that people access those services? So if I can hand over to Stuart, who's going to take you through some of the detail in relation to some of our thinking about the strategy from a clinical point of view and how we might shape clinical services.
Thank you, Abby, for that excellent summary, and well coped with being cut out of the meeting.
So you were all in there, were you? I thought maybe I thought everyone.
No, seamless, Abby, seamless. So look, I was going to go through 3 or 4 areas within the overarching shaping our future well-being strategy. And what Abby's described to you is a strategy which covers population health, it covers prevention, vaccination, it covers clinical services and places of service delivery, amongst other things. And the 3 things I was going to talk to you about, firstly, was the shaping our future clinical services. And this is best described, I think, by the services that you need when you become unwell. So this is not about prevention or population health as such. This is about the management of illness. Now, the next 2 after that would be about places of care, one about community, one about hospitals, and then the 4th thing was about some cross-cutting themes. In terms of shaping our future clinical services, this is a program which will help us redesign our clinical services to make them fit for the future. And we need to do this separately from the work about buildings, because of course with the buildings, form must follow function. And this is what we're talking about here is the function. And what we're designing is a new setup for clinical services based according to those 5 principles that you see on that slide. So a setup, a redesign led by clinicians of all professions, designed with patients and carers, co-design of that service. It's based upon the whole sequence of care, all the way from primary care and community care through to the most complex of specialist interventions. It has to be guided by best practice, evidence-based care and higher standards of care. And indeed, for all of those different components of that care to seamlessly integrate. Thank you. Could I have the next slide? Thanks. Now, there are three areas that this subdivides down into quite neatly, and I'm just going to talk in detail about one and then touch upon the other 2. So the one in detail we're going to talk about is planned and elective care. So this is the care you might receive if you have say a longer term condition, if you, the example given on the slide is if you had a painful hip, and how you might end up then having an intervention for that. If you had to at some point have a hip replacement, that would be a planned intervention. Now, traditionally, the model that would follow is you go and see your GP, he'd refer you to see a specialist. The specialist would make a decision with you about what intervention you required. You would then have that intervention and then a follow-up with the specialist before being discharged back to the GP. So a sort of fairly straightforward pathway, which people keep in their mind. But the reality of the situation that we currently working, and the reality of what that future needs to look like, is it won't be like that. And it won't be like that because the challenges that people face and the challenges that we face as a health board are so much more complex than that now, for all of those reasons that Abby's just described. And so it's much more common now that rather than that simple pathway, somebody might undergo any number of steps, including a visit to a diagnostic centre, a further follow-up from there with in the community, a review then in the hospital, and so forth. And all of those steps can take time and can be inconvenient. And what we're looking at here with this new change is that a number of those steps can be undertaken in a new way and in a way which is much more convenient for the individual. So so appointments which can be undertaken virtually, you can have your follow-up appointment in your home being undertaken in the same way that we're having our discussion now. You can have your diagnostics in the community in one of the hubs that Abby's just spoken about. And you only need to go to the hospital at a point when only the hospital can provide the care that you require. When all of that comes together, you get this much more complex pathway, but a pathway which is much more suited both to the challenges that we currently face in terms of the complexity of the scenario we find ourselves in, but also much more suited for the realities of people's daily lives and how they can have a much more involved integration into their own care. Next slide, please. And that's for planned care, but there are the 2 other big areas of service that we really need to look at: emergency and urgent care, and highly specialised care. Now, emergency and urgent care is when someone needs some intervention they weren't expecting. When you have to go to the emergency department suddenly because you have an injury or an illness that wasn't a planned admission, wasn't part of a long-standing illness. That care you require of the highest possible standard, and it needs to be available to you whenever you need it, 24 hours a day, 7 days a week. Also, can you hear me? So did someone say something? No? Okay. I'll carry on. And the other component is for those highly specialised services, the tertiary services. And of course, Cardiff and Vale is in a unique position in Wales, and it does provide a large number of tertiary services, over 100 of these type of services, and it provides a large number of services both for the whole of Wales and even some services for the whole of the UK. And providing those services is a key component of our future configuration. So next slide, please. So that's the sort of the overarching view of the shaping our future clinical services. So then we move on to the placement for that. Where are they going to happen? And the first of the two work streams I was going to talk to you about in that regard is this one, shaping our future community care. So this is about all of those interventions, and be that a clinic appointment, be it a diagnostic, be it a visit to the GP, be it a discussion with your specialist, which can take place at home or can take place in the community, either in one of the in your GP surgery, or on a larger scale in one of the wellbeing hubs in the primary care cluster, or on a larger scale again in one of the health and wellbeing centres which are planned at CRI, Barry Hospital, or in North Cardiff. And those health and wellbeing centres would give you access to level of diagnostics, level of specialist review, and so forth. And there's a work stream specifically looking at those components, how they fit together. Next slide, please. And then under the other place-based component of that work, which is the shaping our future hospitals, we're really talking in this regard about the two large hospitals, so UHW and UHL. And their paths are starting to diverge a bit. And what we're suggesting is that there might be a future for UHW, which is based upon its national and international reputation, where it's providing those specialist services, the type that come under that tertiary heading to some degree, the neurosurgery and cardiac surgery, renal transplant, and so on. At the same time, providing for the emergency and specialist acute care, that environment required for people who have urgent care, emergency care, and it's available to them 24/7 and can give them all of the requirements that they might require in that facility. And of course, being the University Hospital of Wales would also give us that environment. There's a learning environment for teaching, education, research, and so on. And that's what we're proposing in terms of the future direction of travel for the new UHW. Next slide, please. In terms of UHL already provides a number of very high quality elective surgeries services, so orthopedic surgery, spinal surgery, breast surgery. It also provides rehabilitation, has a state-of-the-art stroke rehabilitation facility, provides cystic fibrosis services nationally, and of course also has an inpatient mental health unit of a very high standard. And we would envisage those types of activities would be the activities provided on a UHL site. So it would be for those people who need hospital care, who are stable, so are not the most acutely unwell end of the spectrum, for those who need planned surgery and need that to be undertaken in the right environment for that planned intervention. And something that Abby referred to as our learning from COVID. We've managed to deliver elective surgery to a very high degree during the COVID pandemic. And we've done that by separating it from urgent care, so that we have these green zones where people can come to be treated safely in a very carefully controlled environment, separate from the care given to those people who are acutely unwell. And of course, in the future, that we still envisage UHL would be the site for all inpatient mental health services. So could we go on a slide, please? Now, this is the last one I was going to talk about, and I'll just talk about the first two items and then hand over to Abby for the environmentally friendly component. But within all of those sub strategies to the main overarching strategy, the Shaping Our Future Wellbeing strategy, there are some themes which come out again and again as being essential components that have to be delivered across all of those environments for all of those pathways, and without which we will be unable to deliver our aspirations of shaping our future well-being. Now, the biggest two, I think, of those are our staffing plan and our digital plan. And it's absolutely essential that we grow and develop the right workforce, multidisciplinary, high level of training, very engaged, have their own well-being looked after, and who participate in education, training and research, and can deliver in a multi-professional way all of the aspects of that strategy that we just mentioned. Getting that right is absolutely key. The second big cross-cutting theme I was going to mention is about digital solutions. Now, We did say at the beginning that digital solutions, I think, Abby, you said, won't suit everyone, but we're all here tonight on a Zoom meeting, having this fantastic evening, enjoying this engagement exercise, and we're doing it digitally. And if we are going to deal with the healthcare needs of our population in the future, I think we really have to we have to deal with this. We have to get this right, and we have to offer all sorts of digital-based solutions to deliver the healthcare requirements of all our population. And I think there's a very large proportion of the population who would be very engaged with that as a way forward. Not everybody, as Abby said, but having access to your records online securely, high degree of information governance, but available to you. Being able to upload information from wearable devices to your own patient record, being able to interact with clinicians via your own portal, all of those types of options are key for the future of our digital provision of services. And I sort of took me a while to work out quite what I meant by the digital future. And whilst having electronic patient records and having electronic prescribing and so forth are key, what it's really about is your experience as users of the service, and how you can interact with healthcare services digitally. And we get that right, and then we can succeed in delivering the aspirations, I think, of shaping our future well-being. So that's the second one. Abby, I was going to stop there and hand over to you for the last bullet point on that slide about the travel and environmentally friendly transport.
Thank you, Stuart. That's been really helpful. And I've touched upon it already. I mentioned that we have a duty to respond to the climate emergency. Back in January last year, our board took a paper and agreed that it needed to respond or up its response to the climate emergency, and we have developed a sustainability action plan to respond to the threat and to recognise the impact that healthcare has in terms of carbon emissions. So we've started work on this already, but again, we need to think about not just a bit about travel, but about our buildings, how well they use energy, how we recycle things like rainwaters, how we design all of those things into the way that we develop our facilities, and that we do so in a way that enables people as much as possible when they do need to come to our facilities, that they're able to get there using active travel, taking the bus, coming on their bike, and the same for our staff too, so that we can play our part in reducing unnecessary journeys. Just moving to the final set of slides, I think there's 3 more to go, but just to give you a sense of what happens next. So as Jan said, our chair at the beginning, very grateful to the CHC for hosting a number of these meetings. So I think this is the first of 5 meetings that we're holding over the next few weeks. As you will see, our thinking's quite high level at this stage. It is engagement. We're not consulting on any specific changes at this point in time. We're really keen to hear from local communities what's important to them as we develop our thinking and reflect on what we hear. So in addition to these public meetings, we have a whole range of other avenues open to people in terms of sharing feedback. So we have got questionnaires that are out with people on the back pages of the engagement document. We get a lot of people communicating with us now via Twitter and things like Facebook. So we get a lot of feedback through lots of different mechanisms, and we're going to a number of community groups, third sector groups, partnership groups, to get feedback from our partners and to some of the groups represented through third sector organisations to make sure we get as comprehensive a feedback as we possibly can. We will pull all that information together. The engagement phase runs until the 19th of April. We are very mindful that the pre-election period is likely to hit early in April, and we'll just need to work through with the CHC. We'll have completed all the public meetings by that point. And then what we will do is, as we always do in engagement, share all of the feedback with the Community Health Council as we draw all of the the feedback together and analyze that and look through what you have been telling us in terms of the things that are important to you. And once we've done that, we will reflect on what we've heard and report that back to our board. And in a sense, that's really about shaping the next steps, and as we developed the next level of detail, I guess, in our plans around how we're going to improve clinical services. So really keen to hear your views, and as we feed those views into more detailed proposals, we will continue the conversation and continue the engagement as we firm up those proposals. Next slide, please, Vicky. So as I said, I've mentioned this already. These are the points that we will signpost people to in terms of where they can find out more information. We've got a whole page on the website where we've got lots of material providing a lot more background and the documents, and we've got email there and our social media hashtag to also provide comments. So I'm very happy if you want to share with family and friends. The more feedback we can get, the richer the feedback will be, and the more we can reflect that in our thinking moving forward. And I think the next slide is the final slide. This is the specific ask. Have we got it right in terms of the challenges and opportunities we've described? Are there other things that you think at this stage that we haven't reflected? I mean, it's a little difficult because this is kind of a summary presentation, so there are probably things on the slides that we haven't reflected, but we've captured in our thinking and in the document, and we're aware of things that we need to reflect on. Have we is it clear from what we're saying in terms of the case for change, the fact that we can't continue to provide services in the same kind of way? Have we set out the right principles in underpinning our emergency and urgent care, the planned care and the specialist care, and what that means in terms of the things we need to have in the community, and just what are the most important things to people? This is people will have very different views based on their own experiences, their own families, the needs of their loved ones. So we recognise it's kind of quite a very personal experience that people will reflect on as they provide their comments. And very importantly, building on what Stuart was saying, how can we enable more services to be provided at home? The feedback, as I said before, on moving to some of the more digital platforms has actually been really positive for many people. The feedback we're getting, it's much more convenient. They can have more family, friends, and family around them as they're having engagement and discussion about perhaps their care plan or the next stage of their treatment pathway. And we know that, for particular groups, a lot of really positive feedback from younger people who find that a particularly good way of interacting. And we know that it's cutting down already massively the number of car journeys that are needing to take place. So these are the sorts of things that we're really interested to hear your views on. So very grateful for your time and patience listening through the presentation. And Malcolm, if we hand back to you, I guess we'll move into the question and answer part of the discussion.
Okay, thank you, Abby. I would like to thank the Health Board's Abigail Harris and Dr. Stuart Ward for their presentation. It is now your turn to provide comments, questions and observations, all of which will be noted for reference as part of the engagement process. And we are recording this session at the moment. So if you do raise an issue and don't want it to be in the public domain, please let us know and we will then edit that out from there. Ideally, I want to afford all present the opportunity to have your say and not to cut short any debate or discussion. I would like us all to adhere to the following requirements. Firstly, could all speakers give their name, and if you belong or are representing an organisation, the name of that organisation and your position within it. This is purely to assist those taking notes. Secondly, it would be appreciated if only one person could speak at a time. Again, this is to assist everyone at the meeting and to help note taker and a recording of questions and answers. If you just raise your hand, either as Jenny has done now, and we'll pick Jenny up first when I finish, or on the participants, you can raise a blue hand, or by sending a chat, we will pick up those questions. Thirdly, I'm sure that I don't have to ask attendees to conduct themselves with dignity and refrain from engaging in any personal attacks or acting in an aggressive manner. We all need to be kind with each other. Finally, I will invite questions and attempt to limit them to one per person in the first instance. This is in order to allow as many people as possible to contribute. It is my intention to finish no later than 9 p.m. Could we have the first question, please? And that's Jenny.
Thanks very much. I'm Jenny Rathbone. I represent Cardiff Central in the Senedd. And I think King Coed is the only area that's in Cardiff and the north. North and west. First of all, I wasn't entirely convinced at the extent of change needed from your presentation in terms of the way in which COVID has exposed a level of health inequalities. And obviously that if we continue along this path, we are going to continuously be an unhealthy nation, and more demands on health budgets and demand for secondary services, which in the end we simply won't be able to meet. So I need a little bit more convincing that you're really grasping the nettle on this one. Secondly, I very much like what Stuart was saying about, enabling citizens to have consultations from home if that's what they want, and also get basic tests in their hubs and only have to go to one of the places like the CRI to get things like x-rays, which obviously can't be provided in every place. I just wanted to probe a bit more about the extent of the services you want to shove on the Heath side. This may be ignorance on my part, but does neurosurgery need to be in a place which is specializing in emergency care? Isn't that the sort of thing that could be in Landoch, which seems to be a calmer place? Necessarily tertiary emergency centres are going to be busy and lots of unexpected things happening.
Okay, so can I come back to that one to start, and then I think Nav, you might want to make a comment about the about that. I think if I can come back with a short answer, the short answer is yes, neurosurgery does have to be there. Nav, did you want to give a slightly longer answer, or shall I? 'Cause I saw you put your hand up, so I didn't want to sort of steal your thunder on that. Did you want to come back with anything more than that, and then I'll come back with the public health message.
Yeah, just to expand on that, what we've looked at, where we've thought about what needs to be cited on UHW as it stands at the moment, are services that require 24/7 high intensity intensive care, and neurosurgery, for instance, definitely falls into that category. Also, neurosurgery is a good example because it includes both things like head injuries. So you have to be close to the emergency departments, helicopter landing pads. I mean, obviously, if you have a head injury, you might also have fractured limbs or heart problems. So we've looked at what requires high intensity, 24/7 critical care, codependencies with other services. So if you have a big major trauma, for instance, you might need dialysis because your kidneys might not work. So we've tried to look at all of the different codependencies and connections between services and work our way outwards so that things that don't need those things can be completely separated, protected, or isolated from those requirements. And so an equation develops as to whether or not you're in that high acuity, high intensity site or that protected pathway rehabilitation stream. And that allows you to divide up quite nicely. And we can explain those codependencies and work on them as we move along.
Thank you, Neb. If I can come back on the population health question, if that's okay. What we've presented here tonight is not the entirety of our subcomponents of the Shaping Our Future Wellbeing strategy. And at the beginning, I think what Abby and I alluded to was that there are other components which we haven't presented here as part of that Shaping Our Future Hospital and Shaping Our Future Clinical Services presentation, which is what this is. Of course, it hasn't quite been named this yet, but there is a sort of shaping our future population health and prevention arm as well, which is the arm which would cover the things I think you're talking about there. So that whole, the sort of the risk factor issues about, say, smoking, weight, exercise, the substance abuse we know is a really high impact factor in Wales, actually. So alcohol, smoking, drugs, etc. So all of those components don't sit within these work streams we've presented tonight. They sit in a separate set of work streams which we haven't spoken about specifically. But please do rest assured, please do take a higher degree of assurance from us that they are foremost in our mind. I think you're absolutely right. COVID has totally demonstrated those health inequalities and how individuals from disadvantaged backgrounds, individuals from BAME communities and so forth are at a greater risk of illness from COVID infection, and as they are from a large number of other illnesses as well. So you're absolutely right to flag it up. It's a key issue. We haven't mentioned it, not because we're not doing it, but because it wasn't part of this evening's presentation, which is covering just a certain set of components.
Okay, thanks, Stuart. Abby, I think you wanted to come in with a response.
Yeah, just to add to what Stuart was saying, that one of the things that we did just prior to COVID is that we developed with our public service board partners a kind of response in terms of prevention. How can we really support communities in terms of preventing disease in the first place? So what we would call primary prevention. So some of the things that Stuart talked about, things like how can we ensure our population has a healthy weight. So things like our Move More, Eat Well campaign that came out just before COVID hit. And we are keen as we emerge through from the pandemic to have another look at that work, as Stuart described, building on what we've done already, but also reflecting one of the things that we talked about in here, which is also around a different way that data will be available to us to inform our likelihood of getting disease and our risks, so that we're using that information with GPs and with hospital secondary care-based doctors to inform care plans that are very targeted and specific around the risk to each one of us, because it will be different based on our makeup in terms of what we might be more at risk of in terms of our health. So again, that will be an important part of the work that we're doing as we move that agenda forward. But Stuart's right, our intention wasn't to focus on that today, but Jenny's right to point out, which is why I started with it, that is a really key agenda that we need to do more work on as we come out of the pandemic.
Okay, thank you, Abby. Anne O'Regan, you wanted to come in?
Actually, they both just answered my question, because I was going to ask about preventative medicine, and I've been part of the consultation on the Parkview Clinic, and I really thought that would be a brilliant opportunity, to be working with health and well-being and preventative medicine. But I was locked out for a short time, and now my question really has been answered. So thank you.
Anybody else got a question they'd like to raise? Laurie?
Hi there. My name is Laurie Lewis. I'm the Director of Audiology at Cardiff and Vale University Health Board. I just have a question for you, for all of you working on the project. So I'm just wondering how you'll ensure that all services are represented in the health and wellbeing centres and the hubs.
Abby, do you want to come in?
Yes, thank you. Thank you for that. So one of the things that we've been doing as we've developed the plans, and it was really interesting to get Anne's comment about being involved in the work on the the Wellbeing Hub in Parkview in Ely, is that we have been going through a process where we bring all the clinical boards together to talk about the services that we ought to be delivering in the community, where they are now, where they could be in the future, what more we could deliver out in the community, particularly reflecting on some of the changes in the way that we think about things in a post-COVID world as we come through the pandemic. So we've been through a process. If I take CRI as an example, where we've done lots of engagement work with clinical boards about what their views are. And we did a lot of community engagement, so we get the views of the population that will be using the facilities to seek their views on what would be helpful to have in the community. And we know that not everything's possible. So, you know, some of the early conversations about what was likely to provide in a wellbeing hub. If I think about some of the public meetings we had in Malvern, for example, you know, there are some things that actually we won't have a critical mass. It won't be an economic way of delivering services to have one in every wellbeing centre. And actually, the conversation with the population was really sensible about that, saying we know we can't have every service we might want, but what are the most important ones that we have available to us? So, you know, some of the conversations we've had around audiology, we know that the West Key model is absolutely brilliant, where delivered in partnership with a GP practice there. And we also know that your colleagues are delivering services in some pretty appalling accommodation at the moment that aren't soundproof, that has to be shared with physio. That, you know, I remember somebody telling me about when we went to visit a service that, you know, that if the bus, you know, they've settled a young person, a young child down to have their hearing test, and they're all ready to concentrate, and a bus rattles past the window and they lose the moment. That's not a good patient experience. If you're the mother of that child, need to come back again to have the audiology test undertaken. So recognizing that we need to provide the services in the right kind of environment and make sure that you've got the facilities that you need to deliver those services. And sometimes that might mean that we're not delivering it in quite as many places, because, you know, if we're going to have an audiology room that's soundproofed and has got all the facilities, we need to make sure that it's used all of the time, and we might not be able to provide quite as many of them. So there is something about how we balance local access with providing the right kind of facilities, and that's a difficult balance. And we've got to hear from populations about making sure that balance is right. And again, it's about making sure that people don't have to come to a centre that might be providing one thing that's not available in their very near community. That they should only have to travel for that for the time that they need it then, but not you know, not if they need to come for a follow-up or a conversation where they don't need the equipment and don't need to have access to a test in a specially confined soundproofed room. So those are the sorts of conversations that we've been having, Larry. So and we've been very grateful to your colleagues for contributing. So and continue the conversations as we've continue to develop the plans.
Thank you.
I think Nav, you wanted to come in.
It was to answer that question, perhaps more specifically in terms of our process. So I don't know, Chair, if it's the right time to do that or not. I did see John Morley put his hand up as well. So I'm happy to just give a little bit more specific response to that question from Laurie, if it would help.
If you do that, then I'll bring John in afterwards. Okay.
Sure. We're just really starting in terms of the process and the methodology of shaping our future clinical services, and Vicky and I came together as a team under Stuart and Abby's leadership just over 2 months ago, actually. So we're just about finishing our first phase of designing the process, and we've actually spoken to lots of clinical groups. I'm sorry we haven't got around everyone. But we will be engaging actively based around future patient pathways, really. So that there'll be, audiology will touch upon various patient pathways. And what we'll be doing is bringing together multidisciplinary professional groups, public, patient representatives, carers, other agencies such as social care, other health boards where it's relevant, commercial partners where it might be relevant. I know it is, for instance, in optometry. So as it happens, we've spoken to optometry, but not audiology. So forgive us for that. But that was more about learning about processes and work they've already done. and pulling that expertise into shaping the way that we're going to run this program. And we expect this program across multiple large and small pathways to run for the whole year, 2021. And during that, we'll be hopefully engaging with every single healthcare professional and allied professional one way or another. So we'll definitely be in touch. I mean, your clinical board, you know, the leadership team knows, various clinical teams know so far, and we're working our way through. So count yourself as having been enrolled by pitching up tonight and asking the question.
Thank you very much.
And we're easy to get hold of as well through the program, and there's an email address that you can engage with specifically. In fact, it's called engage.cav, so we're easy to get hold of. Thanks, Chair.
Sorry, John, you wanted to come in?
Yes, possibly a question for Abigail. As you mentioned, the Heath, designed in the 50s, built in the 70s, is really full at the moment and perhaps not fit for its intended purposes. If you do plan to replace the Heath, where do you think it's going to be? And does it fit in with the council's transport plans for the future?
John, thank you for that question. And it's a very good one, and it's one that I don't have the answer to. So you're absolutely right that we do need to replace it. We know that that the main block of the hospital is now pretty tired, and what we've seen during COVID is that some of the ward areas and places like critical care, it's really challenging for our staff to care well, and they do a fantastic job. And sometimes it's kind of in spite of the facilities in which we're providing care. So we do know that for many of the things that we're now doing, we're not providing the right environment. So the process we have to go through is that, you know, clearly the starting point has to be, so what services do we need to provide? We do need to reflect on the feedback from this engagement about what will services look like in the future. So as you're picking up, you know, one of the highest footfalls, one of the things that counts for many of the cars that come onto our site and the appointments that we have are outpatients. And that is an area that we can expect services to look quite different. And so that, you know, we're thinking about, well, what would we need to design for outpatients in the future if we're delivering many more of those appointments in a different kind of way in the community through a virtual communication, so people can do it from the comfort of their own sofa. So we need to work out what we need to provide. That we do need a hospital, because as Nav says, you know, we've got those high-end tertiary services, the critical 24/7 life-threatening injuries that people will have that we need to ensure we can respond to. So what we will do once we've identified what the services needs to be, we will develop a detailed business case to secure the funding that would be needed from Welsh Government. And we need to test out what are the options available to us in terms of the site. So, you know, one of the options could be clearing half the site at UHW and looking at how you might construct a smaller hospital and then knock the rest of the facility down. That's what some other places have done, like Bristol and Birmingham, where they've kind of built on the same site and sort of knocked down as they've gone along. There will be other sites that will be available to us as well, and we will need to do a kind of options appraisal when we get to that point in terms of securing the best option for the range of services that we need to provide. One of the factors we do need to take into consideration, we've alluded to already, we are doing this in partnership with Cardiff University and our other academic partners, because we also need to take into consideration the space we need to do proper teaching to enable our students to get the very best experience in terms of the next generation of clinicians, and to provide the right kind of research facilities. We know that we could be doing more research, and we've got a really big ambition around ensuring that any patient who could participate in a trial or research is enabled to do so. And we need to think about some of the facilities that we need to provide on site. So in terms of starting the process, we've developed something called a program business case. which is part of the process we need to go through with Welsh Government to develop a very detailed business case. So we've been doing that work recently to just begin to articulate the reason why a new hospital is required, and recognising that we would need to continue to redevelop Llandoch if we want to deliver more services out of Llandoch. Again, we've got similar challenges at Llandoch, an older hospital. It's had quite a lot of investment over recent years, but still some of the core infrastructure needs to be replaced in terms of some of our ward environments. And if we want to do more surgery over there, we'll need more theatres and those sorts of things. So all of those things get tested out as we develop the business case. And it's not until we kind of get fairly well advanced that we actually have to finally select the site, reflecting on the need and all of the benefits that individual site options give us. Just to give you some assurance, we have met, well, we meet on a very regular basis with both of our local authority partners, but we have met very recently with both local authorities to share with them the plans for redeveloping UHW and Llandoch, and you know, very much based on the principles that we've described here this evening about doing more at home, only, you know, replacing a hospital with the right size of hospital, but not with things that we don't need to provide on the main hospital site. So changing our thinking about what needs to be on the main hospital campus. So thank you for that question, John.
Thank you. Are there any more questions? No questions then?
None, there's nothing at the moment, Chair.
No. Well, I think if there's no more questions, then it's might as well bring the meeting to a close at this particular point. So I would say we've now come to the end of this engagement meeting. I wish to thank the speakers for all their input and also the clinicians who have taken part. I especially thank you for attending and feeding in your comments, questions and observations into the meeting. We will ensure that the views, comments and observations you have expressed will be taken into consideration in the discussions that the CHC will have following the end of this engagement exercise in order for the CHC to formally respond to the Health Board. Could I also remind you that your opportunity of having your voice heard is to complete the questionnaire and return as indicated on the form. Finally, thank you all for attending. Can I ask the UHB Chair, Jan, to say a final few words?
Thank you, Malcolm, and thank you everybody for taking part this evening and for expressing your views. As I said at the outset, we really do need the input of the people that we look after, the communities we serve. You're the people that will give us the inspiration to switch these services and move them forward into a way that suits you, the patient, you, the public, you, the community, in the best possible way. So we really do appreciate and welcome your input, please. And could I just take the opportunity to thank my fellow members of the Health Board for their contributions tonight, but also Malcolm, members of the CHC, for the considerable support work you've given us in facilitating today's session and those that are to come. So thank you all very much. Hwyl fawr. Take care.
Thank you and good night.
Thank you. Good night, everybody.
Right.
Thank you.